Natsios, the director of the Scowcroft Institute and the executive professor at the Bush School of Government and Public Service here at Texas A&M. Welcome to today's webinar on the possible long-term medical effects of COVID-19. We're happy to be hosting you virtually today and look forward to a great conversation with our panelists. We have three experts, Dr. Crudo Blackburn, Dr. Glen Laine, and Dr. Gerald Parker. Dr. Blackburn serves as the Deputy Director of the Pandemic and Biosecurity Program at the Scowcroft Institute at the Bush School, conducting research in various aspects of pandemic disease policy and control. She teaches at the Bush School and at the Texas A&M School of Public Health. Dr. Laine is the Regents Professor, Vice President for Research Emeritus of Texas A&M and Director of the Michael DeBakey Institute for Comparative Cardiovascular Science and Biomedical Devices at Texas A&M. He also serves as a Scowcroft Senior Fellow and a summit leader, the summit leader for our annual Pandemic Policy Summit, which is on December 1st and 2nd. You're all invited to attend that if you wish. He is holder of the Wiseman Louis Wirth Endowed Chair in Cardiology. Dr. Laine spent a decade in a clinical department of anesthesiology and critical care medicine at the Texas Medical Center before returning to Texas A&M, where he assumed the role of department head of physiology, pharmacology, and toxicology for approximately 20 years. He spent the past 4 years as the Vice President for Research for Texas A&M. Dr. Parker is on loan right now to HHS working on a pandemic strategy for the United States. He is director of the Pandemic and Biosecurity Program here at the Scowcroft Institute, and he is also a senior fellow. He serves as the Associate Dean for Global One Health at Texas A&M at the College of Veterinary Medicine and is strategic advisor for the Institute for Infectious Animal Diseases at Texas A&M AgriLife Research. Dr. Parker also serves on numerous advisory boards, including the National Academies of Science, Engineering, and Medicine Standing Committee on Health Threats and Workforce Resilience, the FEMA National Advisory Council, the Homeland Security Science and Technology Advisory Committee, and the Biodefense Blue Ribbon Panel, and the Texas Task Force on Emerging Infectious Disease Preparedness and Response. So I'd like to welcome our three speakers, and Dr. Blackburn, if you'd like to begin.
Sure, thank you so much. So what I wanted to start with today is talking a little bit about the neurological manifestations that have been observed with COVID-19, and many of those have lasted far beyond the time frame of the initial illness. So that's why we're kind of putting this into the long haulers discussion today. There's been a series of studies over the summer looking at the different neurological manifestations, which range anywhere from, say, dizziness or confusion to encephalopathy and strokes and seizures and more severe outcomes. And different studies have found different things. So a study from China and also a study that was conducted around June of 2020 found that it's more common in older people and definitely more common in hospitalized people. But there was also a study conducted in October, so a relatively recent study, that found that mild neurological manifestations, that would be kind of like dizziness and those sorts of things, are actually fairly common in the younger population. So even those who have mild symptoms or moderate symptoms, they have been experiencing some of these things like loss of taste and loss of smell, and those sorts of things are neurological impacts. And so one of the things that has been noticed from people who have experienced these manifestations during their initial illness is that there are many, many patients. One study found that up to 73% of the patients, but that varies based on the population that you're looking at, found that people were experiencing things such as headaches, dizziness, difficulty concentrating, memory problems, decreased sense of smell or taste. So even when that sense returns, it might not be as strong as it was previously, and also other issues with weakness or muscle pain, which can be tied back to neurological conditions. And people are experiencing those things far beyond the time frame of the initial weakness. And so there's still more data that needs to be gathered here. We're still obviously learning as we go along, but there is evidence of these longer term neurological impacts from people who are suffering from COVID-19. So that's just kind of my little introductory about the neurological impacts, and I will turn it back to Professor Natsios.
Dr. Parker, would you like to talk next?
Sure. Yes, and Dr. Blackburn's already, I think, provided a pretty good overview, but I just want to call everybody's attention that the CDC just released more information just last week on the long-term effects of COVID-19, and I think one of the important things that's in that summary from the CDC is that there are several now long-term studies that are underway to try to understand, what long-term impacts may be, who's most likely to get them, and whether the symptoms, eventually resolve. This is going to take a long time to really unpack this and understand the long-term implications. But certainly, Dr. Blackburn's already included some of the most commonly reported symptoms to date, include fatigue, shortness of breath, cough, joint pain, chest pain, but others also report difficulty thinking and concentration, depression, muscle pain, headache, intermittent fever, fast beating or pounding heart. Some of the systems that are affected, much more than just the lung, cardiovascular, respiratory, renal, dermatologic, neurologic, and psychiatric. So there's, I think we're going to have to pay attention to this for some time to really understand this phenomena. But I want to also take this opportunity right now to bring up another that I'm going to throw in the long-term category. It's not clinical, but it's our healthcare system, and this is going to require some policy attention. The COVID-19, and I want to bring this up right now because we're on the precipice of another hospital crisis as we're seeing an uptick in cases, and today there's 73,000 people hospitalized in the United States with COVID-19. So this is again stressing our hospital system in many areas of the country, a lot in the Midwest, even in Texas and El Paso as we speak. And there's also had untold financial implications of the hospital system. There are a million less jobs today, healthcare workers working, despite the fact that we've had to surge. We've also had to delay, postpone, cancel other routine procedures. So all these things are going to have an impact on long-term health broadly, not just COVID related, and it's going to have a major impact on our healthcare system that we're going to have to deal with from a policy perspective. And we'll stop there. Thank you.
Dr. Laine.
Yes, sir. So let me just say a few words about, what a long hauler might be. There is no really concise definition. Being still having symptoms after a couple of weeks or a couple of months, take your choice. It's a distribution of populations, but let me just quote a few numbers. And these are numbers from what in one Italian study were considered to be long haulers. And they had to have 2 consecutive negative COVID tests in order to even be considered for adding to this data. And surprisingly, about a little bit more than 80% of the patients 2 months out had at least one symptom. And the symptoms are just what Dr. Parker was talking about, the fatigue, the cough, some others. But what's interesting is that over half of the patients had at least 3 symptoms remaining, which is significant. Now, dividing people up into these groups, what age group they fall into, whether or not they were hospitalized, whether or not they went to intensive care, whether they went to intensive care and were on a ventilator. And each time you kind of worsen the circumstance, they have a better chance of falling into this long hauler group. But I'll tell you that I'm going to talk about kids here in a minute, and there are many, many young folks that are long haulers, as we call them. And I think that one important thing to consider is that if you're looking at a disease that only impacts a relatively small population, the absolute numbers won't be very large. But in some countries, they're starting to open basically long hauler hospitals and rest facilities. just because of the absolute numbers that we're talking about. Just half of those folks is a big number and is going to strain the healthcare system, aside from the primary infections. So here I'll say that we're looking at both physical and mental negative impacts. And I'll say that these negative impacts are not unique to COVID patients. Anyone who's dealt with patients who spend time in the intensive care unit will know about post-intensive care syndrome, or PICS. It's the syndrome of a lack of responsiveness, neural symptoms. They call it the fog. And whether you're there for COVID or for just about anything else, the presence and either being on the ventilator or being in intensive care, it predisposes you to this. I'll also point out that there are many other diseases, so no one should be surprised by the concept of the long hauler syndrome. If you look at shingles, for instance, secondary to chickenpox, much later in life getting herpes zoster, or post-polio syndrome, 30 years later is the most common time for that to erupt, or streptococcal infections causing rheumatic fever, 5 to 20 years post-disease. So the long hauler syndrome itself is not unique, but the absolute numbers could be significant based on the number of people who are infected. I will throw in one point here, and there's the small thing we should be thankful for, and that's even though the number of deaths has been terrible, had this been a disease that had a lethality in the 50 or 80% category, like many diseases around the world do have, we'd be sitting here having a different discussion. If anyone wants to ask questions about it later, many of the syndromes that you see both acutely and chronically can be put into one of two categories. The acute effects, which are regularly attributable to cytokine storm, or your body trying to fight off the infection and the body itself kind of getting in the way. And then various types of blood clotting. So heart, lung, kidney issues associated with emboli formulated in the bloodstream. And I'll just quickly mention that
Dr. Laine, you hit mute.
Sorry for hitting mute accidentally. How far back did I go?
You were just about to, you said I was just about to mention.
Oh, multi-system inflammatory syndrome in children?
Yes.
Okay, good. So it was only a sentence. So children are not immune. There's a syndrome called Kawasaki syndrome, and the secondary effects of COVID in children are very similar to Kawasaki syndrome, and we could go into that's a rash and some other things, usually not lethal, but paradoxically, at least at the moment, until some of the additional studies are done, that seems to impact minorities. About 75% of the patients that we've seen fall into the minority category. So I'm going to stop and let's see what we can discuss.
Okay, let me ask a question that came up. One of our professors in the medical school brought it up, and I called him on it. He's one of the leading experts in the country. And he said that there would be, among many of these complications, these long haul complications, a tenfold increase in the risk of Parkinson's disease and of Alzheimer's disease for certain categories of people who've had COVID-19. Now, we don't know that until people years from now reach the age of 40, because these are people not at age 80 who are going to get these diseases, but at age 40, at much younger. So it's being younger, and it's a much, much higher risk. Glenn, can you talk about that a little bit? Do these long haul consequences include those two diseases? And do they mean people who are very young who could get them?
So, so I'm not familiar with the data, but I can tell you that, as I said earlier, the impacts that you get from the cytokine storm can impact almost every system in the body. And in fact, it's in the nasal clefts, impacting the ability to smell, and other neurological symptoms. And so once these, the cells in various areas of the body, and I'm most familiar with the heart, and we can talk about that. But once they've been impacted, and I'm not talking about chronic infection like you might find with shingles or chickenpox virus. This is just the impact that the cells themselves suffer from the initial disease process. It could predispose you to a lot of other negative outcomes.
Okay. Is there any information on the categories of people who get COVID a second time? That they get negative tested, they're over it, but then it shows up again. So it's the implication that it's hiding somewhere in your system. Can we talk a little bit about that syndrome?
I can make just a quick comment and let others expand. So, you can, when you become infected, and I don't care what the infectious agent is, your body will respond based on its capability and the dose of the infection that you get. And if you don't develop a sufficiently strong immune response, then you may be susceptible to getting the same strain again of any disease. The virus is in fact mutating. The primary mutation, at least that I've been made aware of, it has made the virus more infectious, okay, but not more lethal, which is a good thing. We don't want the virus mutating in that direction. So others have insight into
Sure.
this?
Yeah.
Christy?
Yes, I'll add on to that. So I think that there are really two different things that are happening. There are a handful of cases that look like that the virus maybe never went away and reemerged, and then there's a very, very small number of cases that have been termed reinfection. So they have like a different strain, or they've been infected for a second time. It's not that the virus has been dormant. And those are really falling into two categories in that for some, and again, there's I think either of you can correct me, but I think there's only 5 cases of this worldwide. So it's very small N for information there. But some of them have gotten milder symptoms with the second infection. So they're asymptomatic, or they have a more mild infection than the first. And then there's been 2 cases, I think maybe 3 cases now, where the infection was more severe than the first time. And in those 3 cases, it looks like they have been infected with a variant of the virus that it's different than the first strain that they were infected with. And so there's no real, not enough data right now to know if that's what's causing the more severe infection in that case, or, what's happening. But there is instances where it might have just been a reemergence of a dormant infection. And then there are actual instances where it looks like reinfection occurring.
Barry, would you like to add anything to that?
Yeah, I would just say this falls into like many of the questions that we have. It's going to take time to sort everything out. And there's just, we know a whole lot more about COVID, SARS-CoV-2 than we did just a month ago, but there's still so much we're going to need to learn. And regarding kind of like reinfection or long-lasting immunity, these are going to have implications as we begin a vaccination campaign. And we're going to be learning as we begin to do that too.
So we now know that there are at least 2 vaccines that the United States and the Europeans have invested in. The Chinese have one, and then the Russians have one. The unspoken fear among some scientists is, as I understand it, that the immunity that you receive from getting the vaccine may not last very long. It could last 6 months. It could last a year. It could be like the flu, where you have to get an annual shot. Could you all comment on that? How big a risk is that this vaccine is not going to be good for very long? Jerry, would you
We
like
just
to?
don't know. Yeah, we just don't know. I think it's going to, as everybody knows, we have to get a seasonal influenza and virus immunization. That's because the virus is continually changing and drifting, and that requires it's almost a new virus over time that requires a new vaccine. We just don't know about COVID-19, whether and this vaccine, the vaccine candidates we're producing, what the duration of immunity will be. That takes time. It takes science. It's going to be clinical studies will continue as we begin the vaccination campaign. But I know what I am, for one, glad that we're on the precipice of having maybe 2 vaccines that are going to be under that can be deployed and be made accessible under FDA emergency use authorization. We will see. Those EUA packages haven't been submitted to the FDA, and the FDA has not reviewed them yet. But the clinical results that have been released in the last 10 days have been pretty encouraging from the 2 vaccine candidates that are based on messenger RNA platform.
So there was one report that one of the 2 vaccines requires a -70 temperature to store, or it reduces its effectiveness. But then subsequently, another study was released by other scientists saying, no, we tested it, and in fact, it lasts for 3 months without being at that temperature. Just being refrigerated in a normal refrigerator would work. What is the case, Jerry? Do we know, does it require an extremely low temperature? Because if it doesn't, isn't it kind of impractical?
Yes, one of the candidates does require ultra cold.
Why don't you turn off your video, because you're
-70. The other requires not ultra cold, but okay, is that better? So yes, one of them does, and one of them does not require ultra cold. It's -20. Am I coming through okay?
Yes, you are.
Okay, and so it'll be the FDA, the companies, the vaccine manufacturers have to compile and do the data for shelf life, what it requires. So even though somebody else may do a study somewhere about what kind of temperature it can withstand and still be a viable product, the company has to do that, the vaccine manufacturer, and that has to be approved by the FDA. So as we stand right now, one of them is ultra cold, one of them is still frozen at -20 and -70, and the -70 certainly has some logistical challenges. But again, I would, my perspective, I'd rather be in line to get a vaccine that was at -70. We can work on the logistical challenges, enough data to prove that perhaps it won't require ultra cold at -70, but time will tell.
Okay, Glenn, do you want to add anything to that?
Well, so that's certainly true, and we're fortunate to have multiple vaccines in the wings, and the manner in which each of those was developed is slightly different, and so there could be many opportunities. And I'll just tell you personally, I'll probably pick one from one category and one from another, and over time, get both vaccines. Some may be longer lasting than others. So what happens is, as Jerry was saying, so the companies themselves have to test this. And so if you're in, have some time urgency, you may not be able to go back and retest your vaccine preservation technique to try to get it to be good at -4 or -20 when you actually did the development at -80 or whatever. So will they be able to do that? Sure. But better to have the vaccine available and later be able to distribute it under various circumstances than not have the vaccine at all. And as Jerry was saying, that this data has to be provided by the manufacturer.
Christy, would you like to add anything to that?
I'll let Dr. Parker go really quick, and then I can
Go ahead,
add.
Jerry.
Yeah, I was just going to say, there are actually still over probably 150 vaccine candidates and some kind of vaccine candidates, the operative word candidate, still in development across the world. And there are 5 vaccines that have been supported by six vaccines supported by Operation Warp Speed in the United States. And so these first 2 are the first ones that are completing the phase 3 clinical trials. And there's 2 more that are in phase 3 clinical trials right now. But I think one of the key things that we need to be thinking about immunizing the world, not just the United States. We're gonna be in this for the long haul. So to really begin to get a hold on this virus, we're gonna need to be thinking about global access too.
And you mean global, you mean people from the developing world in particular and middle income, right?
All over the world.
Right.
High, low, middle income.
Exactly. And one of my concerns is we have been ignoring the risk. If we get immunity for our country, but we ignore the rest of the world, we're putting ourselves at risk because.
Well, let me add something to that. I think I think there's some misconception that the United States is not thinking about the rest of the world. I think we are. The amount of investment that we in the United States have made in the vaccine campaign is far exceeds other countries. And so the investment that we, the United States, are making in the vaccine candidates, vaccine development, vaccine manufacture, vaccine clinical trials is going to pay off huge benefits, as well as our other international partners in helping us achieve that ultimate goal of vaccine access for the world. So don't underestimate the amount of investment that we have made. And some of that will be pivoted to international support.
Okay. Jerry, can you talk, since you're in the middle of this now in Washington, about Operation Warp Speed? I wish they hadn't used that term, frankly, but I understand why they did. Can you talk about exactly what that is, what it involves, and why it's important in?
Yeah, I can. I got to be careful. I got to wear my Texas A&M hat on this, not my HHS special government employee hat.
Okay.
But Operation Warp Speed is essentially a vaccine manufacturing campaign that is unprecedented in nature and scope and scale that we've ever attempted in history. And so it is formed a very strategic partnership, at least with the United States. What we've talked about a lot with interagency leadership. And so DOD, HHS, who really are kind of the leaders in the vaccine research development and deployment in the United States are working on this, and it's very focused. There has a very deliberate battle rhythm about the way this program is being managed. There are no shortcuts in the development. The key unique thing is that vaccine development is being done in parallel rather than in series. In the past, all of our vaccine development efforts have been done in series. And so we are beginning to actually even manufacture vaccine candidates well before the clinical trials are done. And so that just means that we're manufacturing at financial risk if the clinical trials determine that it's not effective or a safe vaccine. But the pandemic kind of warrants that financial risk to do things in parallel, but we've never done before.
So are you saying that right now they are manufacturing these 2 candidates that have been announced already, even though the trials have not finished yet?
Yes, they have. They have been.
Interesting. Okay.
But that's how you speak. That's how you shorten the time to development by doing things in parallel. Otherwise, it'd be next summer.
Sure. So Glenn, you talked earlier about the long haul medical complications of COVID-19. Is there any evidence? Are there any studies that would indicate that rehabilitation, one, or pharmacological treatment, drug treatments, could mitigate the effect of these long haul complications?
So if you intervene early, and everyone who goes to the hospital and has to be in a hospital bed gets put on anticoagulants, and so most of the as Jerry said, we need more data. But many of the complications in the lungs and heart are associated with clotting and clots going to the lungs or clots going to the small vessels in the heart, causing heart failure or heart attacks. And the same thing in the brain, where they're having small blood vessels in the brain occluded. So making sure you have good anticoagulation for the patients while they're in the hospital is important. And then there are some other drugs that have been around, something called N-acetylcysteine that's used for, breaking up mucus in the chest. Some things that, again, there's just insufficient data, but they're worth studying as being, indicators of a potential positive addition to the treatment regimes for these patients. I can tell you that the syndromes, as they manifest themselves through heart disease of various types, whether it's infarctions from clots or pericardial effusions or pleural effusions, water in the lungs and in the heart, are issues that I think are going to have to be followed more closely. A lot of the people who are in the hospital, they've actually not done certain imaging tests just because of the sheer numbers that they're dealing with. And even fewer of those imaging tests once the patients are released from the hospital. We may need to follow up to make sure that some of these patients don't get too far down the long hauler road before we intervene.
One of the people listening in asked the question, if any of you believe that we now have sufficient data to say that there's going to be seasonality to COVID-19, like the seasonality of influenza. And the reason I say it is not because it's mutating, or maybe I should put it a different way. Why are we seeing a big uptake? Is it because it's getting cold out and people are indoors more, or people are getting tired of social distancing and you're wearing their mask? What is the reason we're seeing this uptake right now?
You can see why everyone's jumping to answer this question. I'm sure someone else will have a better insight.
I can opine a little bit. I think, again, we're not quite sure exactly why we're seeing it, but I think one thing that we do know right now, there's a lot we don't know. Again, I'm gonna sound like a broken record saying how much we don't know, but what we do know, that we're seeing a lot of the infections right now are actually in groups of people who know each other, and as opposed to just encounters and with people, strangers in public. So it's people who may be going to that know each other, going to happy hours, going to bars, meeting in their house, even in office environments and so forth. So it actually happens to be people who know each other. So that has implications, actually. I know nobody likes to think about this, but it does have implications for the holiday season coming up, Thanksgiving right around the corner. And I know in the Parker family, we're taking some what I would call precautions to make sure that we're just in our household, that we're going to just kind of celebrate with people in our own household. And in the Parker family, that just means my wife and I. And so that's what we do know. I think there's still a lot that we don't know. Travel could be a little bit higher risk, but actually the Army and United Airlines did a study that actually in flight, in the air, the risk is kind of low because of the high air changeover and the HEPA filters in the plane and so forth. But if you're on a plane and somebody's within a few rows of you who test positive later, you will be contacted and asked to test and perhaps go in quarantine. So that's kind of what I know, and I think a lot of that has to do with with the weather and people going indoors, and pandemic fatigue. People want to socialize.
This is an interesting question. I think it's relevant to this discussion. Do individuals that test positive for COVID-19 and then get over it need to get vaccinated?
I guess I'm going
Go
to
ahead.
echo what Dr. Laine and Dr. Parker have been saying. I don't think we have enough information for that right now because we don't know how long immunity lasts. You know, you've seen some studies where there's decreases in antibodies, but I don't know if there's enough data on how well T cells protect you over the long term. And so, I mean, I guess as Dr. Laine said, he might get multiple vaccines. I don't think there would be any harm in getting a vaccine, even if you had been infected. So,
Glenn, do you have
Yeah,
any?
I would say, if you happen to fall into that category, once a vaccine is available, consult your healthcare provider.
So,
Glenn,
I would agree that you need to consult your healthcare provider. But I can tell you what I would do personally, because once you've had the disease, you have no idea unless you get yourself titered so you can determine exactly how many antibodies you have and to what. I'm happy to take a vaccine to kind of amplify that. So the vaccines are actually different. Some of them are made to attack a very specific portion of the viral genome or the viral proteins, and others actually recognize a much larger piece of the virus. And so I'm kind of banking on, those vaccines that rely on a larger piece of the virus giving a little bit better longer term protection. And I'd be in for a vaccine. Personal opinion.
For the record, for the record, me too.
Okay. So one of the studies I saw said that 2/3 of the deaths in the United States from COVID-19 were men, which has risen. It used to be 58%. Now it's 2/3 are men. Can you also reach any conclusions about whether this long hauler syndrome is more a risk for men than women? Does gender have anything to do with risk on this? Anyone?
I don't know.
I think your facts are correct. I think, men seem to be afflicted, and I think maybe females have better protoplasm or something than males do. So I think until we see the long range numbers, it'll be tough to make a call. There is some data on minority populations, both contracting the disease and those succumbing, particularly children, to the long hauler syndrome. So that's going to have to be studied carefully.
But there's no explanation as to why that is. Is it a function of the healthcare system, or is it a function, genetic function, or what's the cause of that?
You ask the tough questions.
I think all of these things we still don't have enough data to say definitively. I mean, on gender, in terms of more men are getting COVID than women, that actually we still don't fully understand that. But if you look at the data from SARS, you can see that men were infected with SARS at higher rates than women. So maybe it has something to do with the virus itself, though we don't have data on that. And then in terms of the long-term effects, I don't know if you're more likely to get it, but if there's a higher percentage of men who've been infected than women in terms of the gender breakdown, then you could see a higher number of men with long hauler, but that wouldn't necessarily mean they're more susceptible. That would just mean that more men were infected.
Okay. Is there any thought being given, Jerry, to creating, I wrote an article with Foreign Affairs that came out in July to create an early warning system based on remote sensing, since authoritarian regimes do not like to give bad news. They control information in a way that a democracy cannot. There's some evidence, substantial evidence now, that this pandemic probably started sometime in late August, early September. It manifested itself in Europe in September. The people just didn't realize it. And there's a Harvard study that shows that Wuhan were suffering, people in Wuhan, from this going back to late August. So that a early warning system might have given us more time to get this under control. Is there any discussion in Washington at all about creating not just one, but multiple early warning systems? So if one system fails, other might work.
I think that's going to be part of the national dialogue as we go, move forward. I think there's still a number of kind of urgent issues at the moment that we've got to deal with just in response domestically. But as we think about, future preparedness, I think surveillance, early warning, and investment in global health security, and how to do that so we have the early warning and response system globally, internationally, that we can one, detect it and put it out before it becomes a major epidemic or pandemic. There's going to be much more dialogue about that in preparedness planning once we get through the crisis. But right now, I think we're still fighting, trying to put the fire out.
Okay, let me conclude with a few questions of more immediate consequence. There's a number of people have asked in questions ahead of time whether or not it would be wise for us to increase the number of classes that are face-to-face this coming spring, or whether we should continue the current restrictions on those face-to-face classes. And two, could you comment on whether we should be relaxing or increasing the social distancing and mask requirements?
I'll comment first just on the social distancing and what I'll call non-pharmaceutical interventions. And I think we are still in a period now, and probably even after a vaccine is starting to get deployed, that our public health non-pharmaceutical interventions are going to be essential. I personally believe that space is the most important thing, but it's going to be critical. You may hear nationally the 3 Ws. I call it the 4 Ws. Watching your space is going to be absolutely essential. Wearing a mask, I think, helps. Washing your hands and staying home if you're not well. Those things are going to be with us for a while. I'm not a fan of government mandates, but I think there'll be some communities that maybe targeted interventions may be necessary, but surgically community mitigations might be necessary. But those 4 Ws are going to be kind of essential, and that's where we as individuals got to take on our individual responsibility to try to slow the spread of the virus in our communities and our homes. I'll let others talk about the other things.
Christy, would you like to add anything to that?
Yeah. In terms of so going off of what Dr. Parker was saying, I think it's going to be very important that we continue to follow all of the precautions that we've had in place from the beginning of the pandemic. I think we still need to wear masks. We still need to stay as socially or physically distant as possible. Those are going to be really important throughout the spring and maybe even into the summer or fall. So this is these are long-term precautions that we need to continue committing to. In terms of whether we should hold more face-to-face classes, that's really I think a university level decision, keeping in mind what we have in terms of cases on our campus and how cases are spreading on our campus, and how well we have wide-scale testing at A&M, which I think is a great advantage to us. But that's going to be a decision, I think, that the university is going to have to make based on how things continue into the spring.
Glenn, any comments?
Yeah, so I'm going to agree with that. I wear a mask, and until we have a vaccine, we need to be cautious. Now, we always need to be cautious, but once the vaccine comes into existence, assuming that a significant number of people become, vaccinated, I'll be vaccinated, so I'd like to have a classroom full of students. It's much more difficult, teaching some in the class and some online simultaneously. But I think the vaccine is the key, and it is right around the corner, and I plan on getting it. And if you, this is a bit of a side, but others, and I'm not here to beat up on anybody, but there's a Russian vaccine, as Jerry was pointing out, that you know, we are fortunate to live in this country and to actually have the warp speed operation in place, because other countries define effectiveness and safety differently than we do. And if you look at the Russian vaccine, they're basically just starting a phase 3 clinical trial, and their equivalent of FDA has already approved the vaccine. And there's, you know, you need to get about 30,000. Our folks have been inoculating about 30,000 people in phase 3. So, you know, it's not an apples to apples if other people start saying all of a sudden that they have vaccines.
There is a vaccine hesitancy movement. I have a more severe term for it, but Christie's told me I need to be gentle when I describe it, so I will. Some of it is based on fraudulent information by a British doctor who unfortunately lives in Austin, who has been running around telling everybody if they take a vaccine shot, their children will become autistic, and which is utter nonsense. But this movement has spread now, and I might add, there's a study done at George Washington University of Twitter, and they found that the Russian government, through Russian bots, are spreading these rumors, equally supportive of vaccines and opposing. And I asked a Russian scholar, why are they doing this? And they said, the person said, to create epistemological chaos so that no one trusts science, no one knows what the truth is, and no one knows what to do, and they're sort of frozen in their decision-making process. And so I think the internet, frankly, has not been particularly helpful in educating people about this. So there is polling data that shows a substantial percent of the American people are not going to get vaccinated. What are the implications of that, Glenn?
Well, okay. So those people put themselves at risk. I mean, that's just, you know, kind of a fundamental thing. But from a broader perspective, it would be nice to get to a point where you had some kind of herd health. But you have to get, you know, it's herd health. And so you have to get to a point where, you know, somewhere, it varies from virus to virus, but say 60% of the population has to have some kind of immunity. And it's a statistical issue. It's not, you know, there's no magic here. So it's kind of like if you have 3 people and one gets the disease and becomes immune, and the second one gets the vaccine and becomes immune. So long as the third person is just hanging around with those people, they're not going to get the disease, you know, even though they're not vaccinated and have never had the disease. You have to be exposed. And so it's a statistical deal. And so, you know, I fully intend to be vaccinated, and my anxiety factor will drop significantly. But, you know, when I'm teaching, for instance, a question might be, do you want to wear a mask when you're teaching, or if you've been vaccinated or already had the disease, do you need to do that?
Christy, would you like to add anything?
Well, I think, yeah, sure. I'll add something really quick. I noticed Dr. Parker wanted to speak. The vaccine hesitancy movement overall has obviously had some implications for things like measles outbreaks and that sort of thing. So, you know, resistance to the vaccine does impact this ability to get to what Dr. Laine was talking about in terms of herd health. And a lot of times when you look at the vaccine hesitancy data, a lot of people it's not like there's all across the country, right? People are clustered in certain areas. So Austin has a really high percentage of people who aren't vaccinated, and a lot of those people attend 1 school or 2 schools. So, you know, for those communities where you have very high rates of unvaccinated people, they're going to continue to be at risk for COVID or for other vaccine preventable diseases if they're not getting those, and that harms the overall ability for the country to get to a place where we have a herd health level that can protect unvaccinated people.
Gerald?
Yeah, and I was just going to add, you may recall that I guess it was maybe, I don't remember, one of our previous pandemic summits, we actually had a discussion about the implications of the vaccine hesitancy issue and pandemic response. And Lisa Kunin from the CDC kind of moderated that panel, and she even opined that that may have been the first time we really had a good discussion about what vaccine hesitancy meant in regards to pandemic response. So I guess we're going to learn in our COVID-19 pandemic what it means. But I think what we need to do now, our public health authorities and community leaders have got to really think about how to do a better job of communicating the importance of vaccines for the COVID-19 response. And you know, in the past, we haven't done a very good job in communicating, and I think that's an area that we need to double down on.
One suggestion I've made in a number of interviews I've done is that because the country is so divided politically, and there's so little lack of trust from one side to the other, and I might have said it's in both sides, it might be that the best messengers for advice on vaccines, particularly in vaccines, may be at the local level. It might be our doctors in our communities, because most people trust their doctors, or hospital administrators, political leaders at the municipal, at the town and the city and the county level, the health commissioners, or religious leaders that people trust. If you had this national campaign at the local level to educate the public and to answer questions of people they trust, I think the rates and vaccination rates would go up. The problem is when you nationalize a problem in a national crisis of the kind we're in, it becomes more difficult to send messages that are received by the great bulk of the population in a constructive way. Anyway, let's just, if we could, allow each person, each one of our panelists to make some concluding remarks. Christy, I'll go with you first. Do you have anything you'd like to add to the discussion?
Sure. I mean, I guess with my concluding remarks would be, I know there's been a lot more research out recently, and I know that I feel it myself sometimes, is this idea that of pandemic fatigue. We've been doing this for months and months, and it feels exhausting sometimes, but I think it's really important for us to all keep in mind that we have to continue to do the things that we've been talking about throughout this conversation, taking the precautions, wearing masks, you know, getting the vaccine when it comes out. All of those things are going to be really, really important to us being able to continue moving forward and getting past the pandemic eventually.
Jerry?
Yeah, I just want to emphasize, and still I've said it many times, that the scientific enterprise has just been unprecedented in the COVID response, and it is paying off. We're on the precipice of having 2 vaccines, hopefully get FDA emergency use approval, and that the vaccine distribution can begin. Again, FDA has to opine first, but just the scientific enterprise and our knowledge advancement, even though we have a lot more to go, we've learned a lot. Even our clinicians today know how to better care for people who are hospitalized severely, and that is saving lives. And so just our response and our learning through the response has just been unprecedented. But it's going to be up to all of us to continue the 4 W's: wear a mask, watch your space, wash your hands, and stay home if you're not well.
Glenn?
So I will concur with my colleagues and say that, and I know this sounds simplistic and it's repetitive, wear your mask, don't get the disease, okay? Get your vaccination when it comes out. That will be the key. I won't comment on those who opt not to get the vaccine. But if you want to keep you and your family safe, get them vaccinated, just like you do for the flu and other infectious diseases. And I'll also point out that although we talked most about physical injury, including potential physical injury to the brain and the nervous system, that we didn't talk much about mental health. And mental health is a serious issue now across the board, and maybe a topic for a different discussion and those more knowledgeable. But I can tell you that that is a serious problem.
Okay,
And Andrew, could I have an alibi on
Go right ahead.
Glenn's comment? Just so 4 words: stay positive and test negative.
Okay, let me just add something. I doubt the students who are dismissive of the risk are the ones listening to this, but just in case you are, those of you who think this is like a bad hangover are full of it. It's utter nonsense to say that, because a substantial portion of you who get this disease, who are young, and students who even have mild symptoms, could have permanent damage to your systems. And dismissing this as though it were a joke is completely irresponsible and putting other people at risk. I've told that to my students. I tell it to all of you now. If you are students who are not taking this seriously, I think, frankly, you're putting your friends and your family at risk and yourself at risk. If it comes out later that the evidence that there's a 10-fold increase in Parkinson's risk, disease risk, or Alzheimer's when you get to be 40 years old, what are you going to say? I should have taken precautions, but I didn't? That doesn't make any sense. And finally, for people who say that people are abridging in the government our rights by making us wear a mask, that's ridiculous. The fact of the matter is, we're not taking people's rights away. We're telling people, just as we would when we tell people to get a driver's license, that they have to go through driver's training and they have to have certain safety devices on their cars. It's required by law. This is the same sort of thing. You do not have the right to infect me because you are acting in an irresponsible way. And that's what a lot of people are doing, in my view, by refusing to wear masks and to socially distance. So there's my little lecture at the end of this. Thank you all for listening. And I'd like to thank our 3 panelists. Have a good day.
Thank you.
Thank you.